and we'll get going here.
All right.
I think we'll get started here. So,
Okay.
well, everybody, happy to present Dr. Maltz and Dr. Deutsch for part 2 of our wellness series. We enjoyed their participation last month, and we'll continue along the same lead. And I welcome both of you. And please, thanks for joining us, and take it away. Thank you.
All right. Thank you very much, Dr. Steinman. So this is our second opportunity to present, and it's a privilege to be able to do it. Today's talk we titled "When the Going Gets Rough for the Tough-Minded Physician." I invite everybody to take a deep cleansing breath. Just reset, and we're going to go over some serious topics. So just keep in mind, this is to open everybody's mind to different thoughts that maybe they aren't exposed to normally, and hopefully you gain something from it. This is only a 1-hour presentation, and hopefully it leads to some more self-care, self-exploration. Let's see. So we don't have any disclosures. I'm an orthopedic surgeon practicing in Houston. I'm in my 20th year. I'll let Dr. Maltz tell you guys about her experience. But doing this mental health, mentorship, resiliency work is extremely fulfilling. And not that I have anything against doing another rotator cuff repair, but after doing 3,000 of them and 5,000 shoulder and elbow surgeries, I definitely feel like I'm doing my mission here. So it's a privilege, and thank you very much for allowing me to do it. So just to start, and Ashley's going to go into the meat of the program, I just wanted to kind of give an update how COVID is stressing an already overtaxed health system. And some of these are excerpts from different Medscape articles that I've come across recently. Doctors care for us day in and day out, but who takes care of the doctor? Doctors die by suicide at a higher rate than any other profession. More than 400 physicians each year end their life. And that was before COVID overstressed an already overtaxed health system. Mental health concerns among physicians are at an all-time high, as frontline physicians face more burnout and stress than ever. Physicians lay down their lives every day. They miss meals as they work tirelessly to meet patients' needs. They spend time away from their own families to care for others. And now, during the worst health crisis in our modern history, they face an unprecedented challenge and work under horrific demands and stress that no human can deal with and not be affected on a deep level. This is an excerpt from a doctor who's a trauma surgeon who lost his job. And this is quotes from the article that he wrote. Even before COVID, we sacrificed time with our families and canceled too many personal moments because that's the oath that we took. And I never thought twice about doing it. Later, as the numbers subsided, I received a call. It was my chairman. His voice seemed stressed as he told me that our health system had tasked him with notifying me and several other surgeons, that our positions had been terminated. Salaries are being cut and furloughs imposed. Termination notices are our new and unacceptable normal. Moreover, to control the corporate health message, the industry is censoring, threatening, and/or firing health professionals who speak out about it. But that is our responsibility. The irresponsible administrative decisions, poor treatment of my colleagues, and unnecessary cutting of essential medical teams across the country is not of fiscal necessity, it's greed. I see waves of programs, services, and providers discarded while overinflated administrative salaries remain protected and saturated with funds. This is a study that was done of the impact of COVID on oncologists and burnout and distress. For well-being participants with a higher level of perceived self-reported resilience, pleasant working conditions, those who felt valued by their organizations, men, those over age 40, reported lower distress and better well-being. And the converse is true. So for example, those under 40 and women reported higher distress. Those working increased hours had concerns about training or career development, self-isolating, reduced clinical trial activity, were at higher risk for distress. And then coming to orthopedic surgeons, there's a culture that exists. It's a male-dominated profession, macho, tough guys. Women make up only 5% of active physicians, although in 2018, 14% of residents were women. But as a whole, the culture of orthopedic surgeons is we tend to hide our emotions, we disassociate from our feelings, we don't take self-care seriously. On the outside, we act as if everything is okay. I asked Dr. Adams to distribute a survey that I received from the American Shoulder and Elbow Surgeons, and it was distributed from a doctor, Dr. Samir Mehta from the University of Pennsylvania. And the purpose of this mental health survey and this study was to determine, does orthopedic subspecialty choice affect the prevalence of depression and/or suicide? And I encourage you, if you do have an opportunity, to fill it out so that we can get statistics on this. And I'm going to hand over the stage to Dr. Ashley Maltz.
Hi, everyone. Thank you, Alan. So also I need to share my screen. We're doing a baton toss, but to just add a little bit to that, the survey that Alan, Dr. Deutsch just mentioned, it has some really profound questions in there just for your own mental, inventory. And so I highly recommend, even if you don't do the survey itself, like just going through the questions and looking at them is really important as you take your own inventory. So the objectives of the talk today, other than what has already been covered, is to review physician suicide statistics, go through a PHQ-9 questionnaire, which I would hope you had experienced in your primary care rotations as a med student, discuss the culture of perfectionism in medicine, discuss along with that imposter syndrome, warning signs to look out for in our colleagues and ourselves, and then how to cultivate resilience and self-compassion. So just a reminder, you've probably seen some of these statistics, and we did talk about them during our first talk. These are old statistics from 2 years ago, August 2018, and these were tracked by Dr. Pamela Weibel. She's an Oregon physician who has taken physician suicide, the epidemic and issue by the horns, and she runs a 24/7 physician suicide and medical student suicide hotline basically for free. She's just doing this on her own. She lectures widely. She gives TED Talks, commencement speeches. She's just doing a lot. She's really amazing. So these are the old statistics, and that surgeons in general make up the highest category of physician suicide. And it's mostly male surgeons, as you can see in the top line, 135 out of 1,013 suicides, and this is just in the USA. There were 867, 146 internationally, 888 physicians, and 125 med students. My line of work falls more along the internal medicine and family medicine. As I didn't introduce myself. So I met you last month, but I'm an integrative medicine physician. That means I blend allopathic medicine with complementary and alternative medicine in an evidence-based fashion. And I see patients here in Austin, Texas, in private practice. So, So 148 surgeon suicides, and then we break it down, she broke it down in her slides, to the general surgeons do have the highest rate of suicide, but orthopedics by subspecialty has the highest rate of surgeons. And the current statistics are running at 55 orthopedic surgeons. So, you know, it's a lot for one not so huge specialty. You know, we have to give you support lines, and there's lots of people who want to help. If you ever think about suicide or are just feeling down and depressed, you can always call these numbers. So there's the Suicide Prevention Lifeline, 1-800-273-TALK, or online, suicidepreventionlifeline.org. September is Suicide Awareness Month as a nation, maybe internationally, I'm not sure. And September 17th was Physician Suicide Awareness Day. So it's exciting. I mean, it's horrible that we have to even talk about these things, but it's exciting that there's more awareness being built and there are more resources being given. There is another support line that was created by volunteer psychiatrists, and that's on the left side of the screen. And that's specific to the COVID-19 pandemic, but I'm sure they'd be open to talking to you about anything. And then you guys do have some resources right in your front yard and all around you. You have the Tennessee Medical Foundation, you've got LifeBridge, Physician Wellbeing Initiative, Next Gen EAP, the Employee Assistance Program. So reach out, do your due diligence, you know, there's nothing worth taking your life over, nothing. So that being said, we're going to take a quick inventory of where you stand right now. And so this is the PHQ. The formatting is off on it's very different than my screen. Anyway, sorry. I apologize for the formatting. It looked different 5 minutes ago. So the PHQ-9, you may have come across it in primary care or psychiatry rotations. It's a validated, highly used depression screening questionnaire, the patient health questionnaire. And basically we're gonna run through the questions, and I would like you to just write down where you stand, what your numbers are. We're not sharing them. I can't see you. I can't see your answers. And no one's taking this inventory but you. And it's just a good thing to know where you are. So in the last 2 weeks, how often have you had little interest or pleasure in doing things? And so the scale is 0, it's up at the top, not at all. So 0 days, several days gets you a 1, and more than half the days is a 2, and then nearly all is a 3. We'll count them up at the end. So felt down or depressed in the last 2 weeks? How many days? How about had trouble falling or staying asleep or sleeping too much? I mean, you're in residency, you're gonna sleep. You're gonna feel sleepy. How often have you felt tired or had little energy? How often have you had a poor appetite or overeaten? How often have you felt bad about yourself, or that you're a failure, or you've let yourself or your family down? How often have you had trouble concentrating on things such as reading the newspaper or watching TV? How often have you had trouble moving or speaking so slowly that other people could have noticed, or the opposite, being so fidgety or restless that you've been moving around way more than usual? How often have you had thoughts that you would be better off dead or of hurting yourself? So go ahead and just write those down. You can tally them up. And then if you checked off any of these, if you wrote more than a 0 on any of them, how difficult have these problems made it for you to do your work, take care of your things at home, or get along with other people? And that's not a score. It's just an assessment. Not difficult at all, somewhat difficult, very difficult, extremely difficult. And there goes my formatting. That's interesting.
I just did that.
Oh, okay, thank you.
Teamwork.
Yes. So you can go ahead and add up the scores, and this is the interpretation of those scores. And again, the formatting, I really don't understand what happened, but it's different.
At least we can see it.
Yeah, it's weird. There was a whole red side of the screen literally 10 minutes ago. So anyway, so 0 to 4, you're minimally depressed, maybe not depressed. 5 to 9, you have mild, it's considered a diagnostic of mild depression. 10 to 14, moderate depression. 15 to 19, moderately severe depression. And 20 to 27, so anything above 19 is diagnosed as severe depression. And these are done, yearly at a physical. It can be done. I do it when I have depressed patients who come in, and we're using the score to track their treatment, and it's just a nice objective measure. So if you scored less than a 4, you may not need treatment. From 5 to 14, your healthcare provider would use their clinical judgment about treatment, and then based on your severity, and obviously you'd have a discussion with them about what you feel comfortable with. And then a 15 would warrant treatment, like for sure. Antidepressant, psychotherapy, and the best evidence is for the combination of both. So what are some potential causes of depression and suicidality in physicians? Oops. The overburdening medical system that Dr. Deutsch spoke of, made currently worse by COVID. Electronic medical records, regulations, malpractice suits, or just the thought of them, all the things in that regard. Isolation, spending 12 to 14 hours in a room by yourself or at work for 16-hour shifts can definitely lead you to feel down. Significant financial debt burden. I'm sure most of you are not unfamiliar with that. Witnessing trauma, death, morbidity regularly as a frontline staff, and really not having time to process it. I think that's where we get into trouble. Our culture of medicine is just keep going, don't feel. And it builds up over time. Obviously medical errors, make mistakes, and people there can be really significant outcomes, and that can play heavily on people's emotions. Substance abuse, which is often how many of us tend to cope with all the other things above. And then there's perfectionistic tendencies and imposter syndrome. So speaking of the culture of perfectionism, there are adaptive and maladaptive forms of perfectionism. So, some perfectionism is not a bad thing. If you're in surgery, you don't want to leave a piece of gauze in a patient before you sew them up. That is adaptive perfectionism. Both of these types of perfectionism have high personal standards. And this is according to psychology research by Hewitt and Flett. But the maladaptive perfectionists when they fail to meet high standards, it's much more stressful for them. And that is clinically associated with depression, anxiety, eating disorders, and other mental health problems. A lot of it stems from socially prescribed perfectionism. So the belief that others will only value you if you are perfect. There's a pressure to perform combined with a sense of helplessness and hopelessness. It's almost a learned helplessness. So you don't have this, you don't feel like you have a locus of control, like you can control your outcome. They are You might present yourselves as perfect. You might avoid situations in which you may appear imperfect and hide past situations in which they or you weren't perfect. So you also demand perfection from others. And this type of perfectionism is associated with depression and suicide. So there's also, you know, a tendency of physicians to have type A personalities. I'm sure we can all relate in some form or fashion. And I wasn't aware where this phrase even came from, and it came from the 1950s. Two cardiologists, Meyer Friedman and Ray Rosenman, they noticed that the higher strung, anxious, ambitious, rigidly organized, status conscious, impatient, and males, generally, workaholic males who are high achieving, they studied them. They saw different presentations in their cardiology practice. So it caught their attention and they started studying them over 8.5 years, and they were found to have 2 times the risk of coronary artery disease when compared to otherwise healthy adults. And this research has been replicated, but it's been shown to impact the incidence of coronary artery disease and not so much mortality over time. We also have come a long way in medical treatment of coronary artery disease since the 1950s. We're also not smoking as much, so that's a good thing. In his book, Dr. Friedman suggests that there are 3 dangerous type A behaviors. Free-floating hostility, triggered by even minor events. So sorry attendings who might do this, but this is the attending who gets upset with a very small issue and throws, you know, the surgical instruments across the room, yelling. Time urgency and impatience, which causes irritation, exasperation, and it's being labeled short-fused. So just unable to relax. And then a competitive drive, which can cause stress and an achievement-driven mentality. That's not to say that all competitive drive and all stress is a bad thing, but it, you know, I think we all need balance in our lives, and we need mechanisms and modalities that bring us down out of this space, because it is pathologic long-term, and it can lead to irrational behavior, leading to suicide. So imposter syndrome. Some of you may have heard this term. I'm not sure if you have or not, but basically it's summarized in this graph. The Venn diagrams do it well. So it's what I think I know might be, is, you know, the assumption that what I know is really just very limited, and it might be wrong, and it's, you know, fraught with insecurities. And then what I think others know, which is like everything, and they're just all so smart, and how do I, you know, compare? And I'm just a complete imposter. I have no idea what I'm doing. That's imposter syndrome, when the reality is actually, I know what I know, and I have experience in my life and doing things the way I've done them. And then other people know what they know, and they have their own experiences, and a lot of them overlap, but a lot of it doesn't. But it doesn't mean that they necessarily know more or are more worthy than you. So this is a phrase coined in the 70s by 2 psychologists, Dr. Pauline Clance and Suzanne Imes. And it's defined as an individual experience of self-perceived intellectual phoniness or fraud. So you can have all of the internal acknowledgement of accomplishments and, external validation, yet still consider yourself completely incompetent. That is what imposter syndrome is. And it was found to be more common in high achieving women. However, studies now show that up to 70% of people experience this at some point in their careers. So it's becoming more widespread, or at least maybe they're studying it more. I'm not sure, but it is an issue. So what are some warning signs that are red flag alerts? You know, in medicine, we like red alerts. I'm gonna play this video. It's really well done from the Mayo Clinic. We were just talking about Mayo.
Medical training is challenging.
It can be frustrating.
Exhausting.
Overwhelming, especially when things pile up on you.
My marriage is coming apart. I took out $183,000 in loans.
I made a mistake. Bad one.
Sometimes I feel like I'm in over my head. I just don't feel prepared.
Sometimes I think the real mistake was thinking I could be a doctor.
We all have our ups and downs, but if somebody starts acting really down,
Not able to sleep or sleeping too much.
Shutting her friends out, giving her stuff away.
If somebody just doesn't seem like himself.
Not doing things he used to love.
Showing up late, not getting things done.
if somebody starts acting reckless or irritable,
Yelling at nurses, snapping at patients.
Drinking too much.
He might be feeling burned out, or depressed, or hopeless.
People who are smart and talented, they get overwhelmed just like anybody else.
And when they do, they may find it even harder to ask for help.
Medical students and residents have higher rates of depression and burnout than other adults.
they have a higher risk of suicide too.
That's something we all need to understand. The risks and how to look out for ourselves and each other.
And when it happens, people say, I had no idea. I thought he was just upset.
I thought she'd get over it.
I wish he'd come to me. I wish he'd said something.
I wish I'd said something. And now it's too late.
Suicide can be prevented. If someone you know is acting differently or really down,
Don't assume he'll get over it.
Say something. Say, are you okay? How can I help?
The best way to prevent suicide is to show you care and get the person the help he needs. So don't be afraid to ask straight out. Are you feeling so bad? You're thinking about taking your life?
People want someone to ask. They want someone to care. Faculty, peers, friends, anyone can ask.
Are you thinking about killing yourself?
And if she says yes, or maybe, or sometimes, here's what you don't say.
That's crazy.
One mistake isn't worth killing yourself over.
that's not going to solve anything.
What you do say is, I'm sorry you're feeling so bad. How can I help?
We'll get through this together. Let's get you some help.
Assume you're the only one. We'll reach out and get this person the help she needs.
None of us should be ashamed of getting help.
Getting help is the strong, professional thing to do.
Let her know she has options, that there are people she can talk to.
Let her know she can always turn to you. Make sure she has the National Suicide Lifeline number.
And help her find someone she can talk to. Someone who knows how to help.
Ask the dean for student affairs or the program director.
If you think she's about to hurt herself, don't leave her alone.
Take her to the emergency room. Call 911 if you have to.
We all get down. We all have our bad days. But sometimes it's more than that.
If you think something's wrong, the only way to find out is to ask.
Are you thinking about ending your life?
Don't wait until you're sure. Trust your gut.
It never hurts to ask. It never hurts to care.
It can make a big difference.
Any one of us can make a difference.
All the difference.
In someone's life.
So that's that suicide hotline again. And again, so what to look out for when it gets rough for the tough. You guys, you know, we are, physicians as a whole are some of the most resilient, tough people on the planet. And, but yet we go through hard times and it's okay. So things to look for: sloppy work, irrational behavior or outbursts, daily or excessive use of alcohol or drugs. Actually, one of the highest suicide fatality rates is for physicians is anesthesia using fentanyl. So that's happened at my university where I trained multiple times. Short-temperedness, suicidal ideation, demeaning speech, lack of grooming, feeling hopeless, isolation, and giving away personal possessions. And then you've got the non-specific psychosomatic symptoms of depression. So abdominal pain, that's specifically in kids who are depressed, back pain, change in weight or appetite, constipation, fatigue, headache, insomnia or hypersomnia, sleeping too much, joint pain, neck pain, weakness. So I'd like you to just take, let's take a step back, take one, second or a few seconds to just consider what you can do when you're feeling like you're emotionally drowning or even psychologically drowning. What is one action you can take when you're feeling that way? Who can you reach out to? Do you have a support team? Maybe your spouse or partner, your colleagues, friends, a family member, a therapist, clergy, community, anyone. The grocery store clerk, I'm not joking. If it needs to be anonymous, do it. Could you actually be completely and totally vulnerable and honest with your support team? And if not, why? Can you look at that, and get real? Like, what, I don't trust people, I'm scared, whatever it is, it's important to look at it and be prepared, because things happen and things go wrong. And sometimes you need support. Oftentimes we all need support. So switching gears a bit, we're going to talk about resilience and thriving and flourishing. So resilience, you've heard the term, I'm sure. What is it? And this is from the dictionary. This is the capability of a strained body to recover its size and shape after deformation caused especially by compressive stress. You guys see this frequently in your trauma patients. It is also an ability to recover from or adjust easily to misfortune or change. And I like this definition the most. It's the ability to become strong, healthy, or successful again after something bad happens. There's a whole movement in psychology called positive psychology, where the focus is on your strengths instead of focusing on the negative parts of your life. So instead of all the problem areas, you focus on strengths. And this was started by a psychologist, Martin Seligman. So you think about the contentment with the past, the happiness in the present, the hope for the future, individual virtues and strengths, courage, compassion, integrity, curiosity. But yet, there was a study done just this year showing resilience versus thriving. And 30% of doctors scored who scored highest on resiliency scores also had high rates of burnout. So just because you're resilient does not mean you don't feel the effects of the current system, medical practice, patients, family responsibilities, all of the life domains. So what positive psychology does is it supports the healthy behaviors. It helps you manage your stress. It focuses on boosting mood and increasing your motivation, improving performance, greater life satisfaction. And this was these are some of the positive benefits that have been found in research through my colleague, actually, Liana Leonov, who I've known for a long time. She's involved in the American College of Lifestyle Medicine that I used to be a board member of, and she just wrote a book that came out, Roots of Positive Change, Optimizing Healthcare with Positive Psychology, and I have it sitting right here, and I'm excited to delve into it at some point. So there is more to learn about all of this. She's studied it for a long time, and she teaches it, so it's really exciting. So types of positive psychology interventions, there's gratitude, keeping a gratitude journal, character strengths, just focusing on what you're good at, positive goal setting, thinking about the long term, not the short term. So you want to be a great surgeon at the end of your residency, and you're just thinking about that instead of all the little nitpicky details that might bring you down. Optimistic thinking along those lines, positive reminiscence, so thinking about things in the past that are positive or in a positive light, savoring things, be it chocolate or time, that's my favorite, or time with your loved ones, mindfulness, just being present in the moment and not thinking about the past or the future. Acts of kindness, service is like probably one of the best, I think. So volunteering, getting out, helping others, forgiveness, and then there are lots of other activities and things you can do. The end goal of positive psychology is to end up in flow state, and that's when you're feeling really in the moment and present, and you can. It's a concept created by Mihaly. I'm not going to even try to pronounce his last name. I think he's somewhere in Europe, and he wrote this book, Flow. But it's when the challenge and the skill are in the perfect state between anxiety and boredom, and you're stimulated, but you're not overly anxious. So I would hope that at some point in the day, when you're in surgery, a lot of surgeons report being in flow state. You lose track of time, you're in the moment, you're present, you're enjoying yourself, and that's all you can think about. There are scales you can take or give your patients or your friends or loved ones, whoever, about flourishing, leading, and they focus on the positives. You're leading a purposeful, meaningful life, you have engaged social relationships. I know it's hard right now because of COVID and social isolation is rampant. But connecting through online programs or just having distance visits outside, whatever you need to do, it's important that you do it. Feeling like you're a good person and just being optimistic about the future and feeling like you have self-respect and people respect you. These are all positive characteristics that are higher on the scale. You can write yourself a prescription, or your program director can write yourself a prescription to be in the flow state 1 to 3 times a week, dose unlimited, and it's just being completely absorbed. You can also do this for patients. If you feel like there's a patient who's kind of down and depressed, give them something to do. They love this stuff. And coming from their doctor, they eat it up. You might get high scores on the Press Ganey from that. So meaning and purpose activity prescription as well. So these are all from Dr. Leonov's research and her book and her presentation. There is, a whole nother line of research, I guess you could say, on self-compassion. And there's a leading researcher here at UT in Austin, in Texas, not Tennessee, Kristen Neff, who this is her life body of work. And I'm gonna play, so rather than explain it, I'll show it to you. It's a shorter.
Hi, Kaz. Hi, Shelley. As you know, we are producing a course called The Power of Self-Compassion. So we're just talking to people today about how they treat themselves. Do you have a critical voice? And if so, what do you find it saying to you?
I definitely have a critical voice. I think everybody does. And I think they all start from when you're a kid. So, I think all the things that my parents said, I hear, but it's normally about not doing a good job.
It's constantly stopping me as I try to complete thoughts or try to make steps forward.
It's a voice that always tells me that I'm not enough, or that I need to do better, or that there's something about me that I have to change.
When you fail or make a mistake, what types of things run through your mind?
I'm not worthy. Everybody's going to see my mistake. Nobody else makes mistakes like I do.
You're stupid. I can't believe you forgot something easy. This was basic. Why are you having so much trouble doing something so simple?
People don't want me around, that I'm uninteresting, boring, and or just too weird for people's company.
It says that I should have done better and
Sometimes it says mean words about myself.
It's probably the loudest thing that's usually coming through my head before anything else is at least ringing that failure over and over again.
And let me give you a scenario where a friend of yours comes to you, has made a mistake, and what would you say to that friend?
Well, the first thing I would tell them that it's okay. You don't need to feel all the weight of this.
Most likely you're holding on to this more tightly than anybody else.
This in no way, reflects your character or reflects your ability to do something. Definitely a lot kinder to my friends than I am to myself.
How do you think you would change if you used that same voice that you use towards your friends on yourself during those moments of failure and mistakes?
I think it would be, incredible because you're not going to talk to your friends the way that you talk to yourself sometimes. And I think that if you're constantly kind of reassuring yourself and letting yourself know that you are enough, then your thought process will change.
When you treat yourself like you do somebody else, you start feeling better, I think, right away, and you keep it in context much more instead of letting things be blown out of proportion.
I think I would have a lot less anxiety in my day-to-day. I think there would be kind of a weight lifted.
It would definitely make me feel better and happier, because when I usually say, when that voice that says mean stuff in my head, I'm not really happy and sad.
How could the world look differently if we were more compassionate towards ourselves?
I think the world would work better. I think through compassion and self-compassion, we all would just recognize that we're all human.
As a society, we could learn to love one another and show that love on a regular basis. I think that this world would be perfect.
There's a saying that if you love yourself, then you can love others. Well, sometimes I believe it goes in the reverse, and that if you can show that compassion that you show to others and bring it into yourself, I think that's where true growth can happen.
I think it would be magical. That's really the only word for it. Magical, to be able to reflect on ourselves from a place of love rather than criticism.
So there's lots of interesting things that popped up. So they do have a 3-video series you can look at. They have a course you can look at, and then there's this. It's okay to feel like S today. That's fascinating. And then Dr. Panda was so generous to send me the Oath to Self-Care and Well-Being, and I love this. This is so progressive. This is so forward-thinking. So thank you, and your university is way ahead of the curve here. So I invite you all to review your Oath to Self-Care that you took. I would hope that it was given to you at some point, and maybe you said it out loud. I don't know, maybe you read it, maybe you didn't, but I highly recommend you do, because if you don't take care of yourself, you can't consistently, sustainably take care of others. And take it from me, I've learned the hard way. Take it from all of us, the older and wiser ones. You have to take care of yourself. So we will take questions if there are any. And then if anyone has questions from there, here's our contact information. You can always find us through Julie, Dr. Adams, and Dr. Steinman. And yeah, we'll go from there. I'll stop my share.
That was great. Thanks, Dr. Maltz and Dr. George. Thanks for joining us. I did have a couple of questions if I could start out. First of all, I did the survey a few days ago, and right, it's kind of takes you through a lot of stuff, and it makes you think about a lot. It's very, very serious and deep, so to speak. And Dr. Mehta has done a lot of work in that area. One question early on, you said that those over 40 seem to be more resilient, and we kind of accept that. When people in their 60s and 70s and 80s tend to accept adversity better. Has there been any work on why that is? Why we always assume that, we know that, but why does that happen as we age? Obviously, you get a little bit more financially secure, and other areas you have a growing family and such, but has there been a closer look at that at all?
Not sure if I can quote a scientific study, but the concept that resonates with me is wisdom through experience. And, every failure you have, if you internalize it and realize what you can do better next time. So I think it's from just life experience where, I have an anecdotal story. I remember being a second year in the emergency room, and I had probably 4 or 5 fractures, and there was an emergency coming in, and my chief resident came down and he just calmed me down. So when you've seen it before, when you've done it before, and you realize, if there's a bunch of clouds, there's a blue sky above, it's going to pass. So I think for me, that's probably what it is. It's, been there, done that. I know this is going to pass.
I think it's also learning, as with wisdom, you learn not to sweat the small stuff. Like the little details that might bother you as a younger person are just, you can see a bigger perspective. You're like, this is not going to affect my life trajectory, and I'm going to let it go. So hopefully, but I would say a lot of the orthopedic surgeons that have, killed themselves over the years are in their 50s. And so there is some, I think some are associated with malpractice suits, and, Pamela Weibel has kept track of, as much as she can, get as much information of why. So someone was substance abuse and being, reprimanded for that. And one was, a malpractice suit, so there are specific reasons why doctors take their life.
It reminds me of a quote I heard, don't sweat the small stuff. And by the way, in the end, it's all small stuff.
Yeah. Yeah. Truth is, we're only here for whatever time we're given, and we just have to make the most of it.
It's interesting. It's well known that men, by far, and looking at the statistics, even OBGYN, where there's not that many men proportionally, have a higher number of suicides. And you touched upon a lot of things, men versus women. Do you think some of that comes from the breadwinner, or is it more just the response to an emotional trigger?
So I'll take that one. The research that I've seen is that men are more successful with suicide. Women are actually at higher risk. Women physicians, for some reason, I don't understand it, but these are the numbers I've seen. They're at 2.5 times the risk of male physicians. However, of females in general. And men are more successful. They use more violent means of taking their life. So guns, hanging, and there are unsuccessful suicides. We all, hopefully you haven't seen that, but it happens. Women are more likely to do an overdose or attempt at an overdose, and slitting wrists, which may or may not happen, anyway, those are the statistics that I've seen.
I would say from a standpoint of men aren't really in touch with their feelings. They really don't talk to other people. And so until the very end, they internalize it. So whereas women, they tend to talk, and they have outlets, and they have ways to work through the emotions. So I think that's a big reason from what I've read is men in general internalize it. They act like everything's okay. And they don't have, you don't get around with a bunch of guys and they drink beer and start talking about their feelings. So whereas women, they tend to do that. So they're naturally predicated to, resolve a lot of issues through talk therapy.
The other thing that I notice is it seems like a lot of men, pride and honor seem to be very important. I think about when I was in the Navy in Washington, D.C., when I was there, the head admiral, the guy that runs the whole Navy, very successful, the only enlisted member that went from the lowest rank all the way through the enlisted, then became an officer, became a top admiral. He was accused of having he's got a whole chest of medals. and one ribbon from Vietnam that he said, "You don't deserve to wear that," and he killed himself. And at the time, I was like, "Really? You're the head of the Navy. You're so successful. You did it all the way from an enlisted person, yet it seemed to be just about pride and honor." But I found that hard to believe, that there must have been a deeper story. But it seems that pride and honor may play a big role for men.
And identity. I mean, when we fully identify only as this is who I am, and if something that topples, you know, and that's your entire identity, it can be devastating. I mean, it's devastating for a lot of people, but it's about how you deal with that. That's the difference. And I can't speak for, you know, everyone, but I would say just reach out. People care. That's all that, you know, your life is important.
And one thing I think you guys touched upon it, but exercise. There have been studies looking at just that variable of exercise as a tool to help a stressful life. When we talk about exercise, is good for us. It, you know, lowers your blood pressure. It, you know, takes your mind, allows you to get your anxieties out, perhaps. Are there good studies showing that that truly has an effect, or do we just assume that has an effect?
Well, it absolutely has an effect physiologically, like on every part of our body, specifically the brain and the heart and, you know, the lungs, everywhere, everything. So yes, there's lots of research out there on exercise. And for depression, anxiety, all pretty much most mental health issues.
Well, I think we're getting, I don't want to ask all the questions. We're getting close to the end of the hour, and we all need to be respectful of our time. Any other questions that the group has? I do know that we did have a little bit of difficulty of people signing on in the middle there, so we missed a couple folks, but we're recording it so they can watch that later.
Well, you're all always welcome to email us, you know, so if you think of something that you want to ask or want to clarify, or if you need help, we're here.
Yeah, and if there's anything specifically to cover for the next time, is, you know, send us any topics or any kind of specific questions. We can tackle that. We can make this more of a interchange so that we kind of do questions and answers rather than doing only lecture. So just, you know, give us feedback.
Well, I think we'll finish right on time. I want to thank you guys for zooming in, Alan and Ashley, and Julie and I will be in touch. And again, stay healthy, and we appreciate this very much.
Thank you very much. Take care, everybody. Thank you.
Bye-bye, guys.
Thanks.